Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2024 Physician Fee Schedule, MIPS, MSSP, and SDOH. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to questions posed after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. And with that, I would like to introduce our presenters, Lori Foley and Martie Ross.
Hi, everyone. Welcome to our January 10th webinar on the 2024 Medicare Physician Fee Schedule, MIPS, MSSP, and SDOH. Martie Ross and I are excited to join you. Hope everyone had a great holiday and that your new year is off to a good start. We are continuing the conversation to dive into the 2024 Medicare Physician Fee Schedule, which brought a great deal of information for everyone to digest and begin implementing and considering as you get your 2024 underway. So with that, let's look at our agenda for today. As expected, we're going to spend some time on the Quality Payment Program, specifically the MIPS payment system and changes that are in place for 2024. And then we will turn over to the MSSP and talk about the services that have been added in 24 to address health-related social needs. So you will see a veritable alphabet soup as we go through our conversation today. We look forward to digging into this some more and seeing the questions that you all have as you have evaluated how it will impact you and your provider group. So getting started with MIPS and the QPP, the Quality Payment Program, you might recall that MIPS is a result of the Medicare Access and CHIP Reauthorization Act of 2015. And if you've been in healthcare long enough, you might recall that this was the replacement for the sustainable growth rate dilemma that we found ourselves in every year. So MIPS has continued to grow and evolve. Some have hoped and wished fervently that it was going to be sunset, but alas, right now it does not seem to be in our future that is on the way. Instead, CMS each year is continuing to grow and evolve and modify some of their requirements, and as we'll talk a little bit further in this conversation, moving towards and really kind of getting everyone to push towards the MIPS value-based, the MIPS MVP program, which is kind of more of a refinement of the processes that we go. So just level setting at the highest level, recall that MIPS is traditional MIPS is comprised of 4 quadrants. We're going to spend some time talking about the changes in each of those 4 quadrants. Those quadrant weights for 2024 will be the same as they were last year in 2023. So quality and cost are equal at 30%. Promoting interoperability, remember that's the former meaningful use, is 25%, and improvement activities are 15%, unless a specific organization is reweighted, and we'll talk a little bit about that in just a few minutes. Data completeness, in the proposed rule, they were proposing to have data completeness, which for most providers and eligible clinicians is relating to all payers and all patients. That threshold will be 75 as finalized in the 2023 MIPS for 24 and 25. They decided to hold it at 75% in 2026. And right now, 2027 is open. They had proposed to increase that threshold to 80%, but based on comments and feedback, they felt like that would be unduly burdensome right now to eligible clinicians, so that 80% increase for 2027 was not finalized. So these thresholds will apply for all eligible clinicians in the quality quadrant, with the including the newly created Medicare CQM collection type, and that's related to the Shared Savings Programs, ACOs, which Martie will dig into a little bit more when she presents shortly. But for those programs, the population is limited to traditional Medicare fee-for-service beneficiaries. For everybody else, it doesn't matter what payer the patient is associated with. It's all payers and all patients, and 75% of the data is required for successful reporting. So when we look at the quality measures, there are 198 quality measures when we're done. They have added 11 measures, including 1 composite measure. They've added 6 high priority measures, of which 4 are patient-reported outcomes, and made changes to quite a few. You see here 59 existing measures. So even if you have historically reported on certain measures, it will be important to go back and pull down the information on each of those measures to understand if any of those changes impact yours. They've also removed 11 quality measures and partially removed 3. We're going to dig into that a little bit further. Recall that providers in traditional MIPS must report on 6 quality measures, 1 of which must be a high priority or an outcome measure, or 1 complete measure set or a MIPS value pathway, an MVP. And if you report more than 6, recall that CMS will score all that you report, and then they will take your highest 6 when they do their scoring. So we'll dig into scoring a little bit, but as you're selecting measures, if you're not sure if your group will perform well on one over another and you can find 8 or 9 that apply in your setting, then there is value to going ahead and reporting for all of them, knowing that you'll get the benefit of the ones that you perform best on. You see here too, they did finalize the requirement to use a Spanish translation of CAHPS for MIPS survey, if that's one of the quality measures that you will be using to report. They were looking to require additional languages as well. They didn't do that. They stopped at the Spanish translation, but they do recommend that you use other applicable languages such as Cantonese, Korean, Mandarin, Portuguese, Russian, and Vietnamese are all available. I just wanted to list here, we won't go into details on each of them, but on this slide and the next slide, you'll see the quality measures that they removed from the inventory. I just wanted to call your attention because some of these are commonly used measures. For example, 107, 110, and 111 will be, they're removed from the general inventory for traditional MIPS, but they were carried over to MVPs so that they could be utilized under there. But some of these measures are commonly used for both primary care and specialists alike because they're easy to track, they're easy to aggregate the information, easy to obtain from the patient, and then easy to report on. And so wanted to call those out. And then this slide shows those additional measures that are being removed. The partial removal of the 3 quality measures, or the ones that I just referenced, are being transitioned from traditional MIPS, but are retained and really kind of expanded. They're more robust and they're more comprehensive as they've been integrated into some of the relevant MVP inventories. So those in particular, breast cancer screening, colorectal screening, and then BMI. Again, common measures that most of the EMRs are able to support. Many providers of all specialties have been able to kind of integrate that data collection into their patient visit. And so they are ones that if they're on your radar, you want to kind of have that in mind. Data, remember, on quality is gathered for a 12-month performance period and is submitted by the provider eligible clinician to CMS. There is special planning. CMS has continued to affirm that transitioning from one electronic medical record to another is not an extreme or uncontrollable situation, happens quite regularly. So as you are making those transitions or planning, if that's in your future for 2024, you'll need to be able to get data from both your old system and your new system, aggregate that data into one report, and then ultimately submit for your 12 months of information. So plan ahead for that process as you're working through that operational pieces. So shifting now to cost. Cost was interesting this past year, meaning if you got your reports over the summer for 2022 performance year, that was the first year that cost was scored for many. And several providers were heavily impacted by how that scoring metric took place. And I think this is one area where a lot of providers feel like they have the least amount of control. And this is probably a year to start doubling down and really trying to get your arms wrapped around understanding cost. We could probably spend a whole webinar on cost if we too could fully understand all of the implications as they go through. Note that some of the finalizations in 2024 were actually for performance year, and when you see it in this slide, PY is performance year for performance year 2022. So if you look at the cost or think about cost holistically, the goal is to improve quality, decrease cost, and MIPS will start to measure how we move that cost continuum, how we bend that cost curve, so to speak. So for 2022 performance year, retrospectively, there is 0 points allotted for improvement, but starting with 2023 performance year, it will start to be calculated without statistical significance. That was kind of a limiting factor as they were trying to get information and make comparable benchmarks. So they expanded the capabilities so they could calculate that. And then going forward, we will see right now a maximum cost improvement score of 1 percentage point out of 100 percentage points. Again, where we see changes where cost is decreasing essentially. There are 29 cost measures. You see 2 that are, I'm going to say, applicable to everybody, most everybody, provided you meet certain minimums, but the total per cost capita, and then the Medicare spend per beneficiary clinician. And then there are 27 episode-based cost measures. In 2024, they've added 5 new measures that have a 20 case minimum. You see those here that are related to psychosis and related conditions, depression, heart failure, and low back pain, and then focusing on care in the emergency department setting. And then they also removed simple pneumonia with hospitalization. So with each of these categories, you'll see if you look on the QPP website that there's a quick start guide and there's some deeper dives into these particular measures so that you can start to dig in a little bit more. Look at your data from last year and the prior performance years to see if you can start to find trends within your entity and practice that you can start to influence how cost is affecting your final score. Remember, you don't report costs. That's calculated solely from your administrative claims. Improvement activities I kind of look at as, probably the least burdensome to most practices because it's really integrated into the operations of your practice. You report via attestation. The performance period is a 90-day performance period. So remember that quality is 12 months. Cost is calculated in the background based on claims. Improvement activities is a 90-day run. If you are reporting via a group, then at least 50% of the providers within that group must perform these improvement activities. And if you're reporting individually by eligible clinician, each clinician must perform the required activities to choose from. Based on certain points, each of the activities has a different weighting. They've added 5 activities and they've removed 3, as you see here. So hopefully these open up some new opportunities if you're struggling to find good improvement activities for your organization. Promoting interoperability, there were some significant changes. These were as proposed in the 2024 rule. Specifically on the left, you'll see that for these provider types, these eligible clinician types, CMS discontinued automatic reweighting for promoting interoperability. So PT and OT, speech language pathology, audiology, psychology, and dietitians and nutrition professionals. I put an asterisk here beside the qualified audiologist. When you look at some of the summary documents, and CMS is comparing 2023 and 2024, they failed to include audiology in the list. But if you read it in the inverse, they clearly state that the only provider type that they will carry automatic reweighting forward for will be clinical social workers that you see over on the right. Now, there are special statuses that apply to all, provider types, all sorts of provider types. So physicians, nurse practitioners, PAs, etc. And those are the second 4, the 4 bullets on the right associated with those providers who practice exclusively or majority of their time in an ambulatory surgery center, they're hospital-based, they're non-patient facing, or they're in a small practice. And for small practice, that's 15 or less providers. For any of those providers on the right, CMS will automatically reweight the weight for promoting interoperability and redistribute that to quality, increasing that to 40%, and then increasing improvement activities and leaving costs the same. Doesn't mean the other providers can't apply for a reweighting, but historically that happened without having to make an application, and now CMS is making that will take away that automatic component. They also increased the performance period for promoting interoperability this year. It increased from 90 days to 180 days. They did this to align with the hospital and critical access hospital requirements relating to meaningful use. So just trying to align disparate programs so that there was some more consistency there. They also modified the exclusion related to the query of the the prescription drug monitoring program, the PDMP. The prior description was a little bit too broad and didn't acknowledge the fact that some providers don't prescribe Schedule II opioids or Schedule III or IV drugs during the performance period. So they kind of tightened up that measure. And then for the SAFER guidance, the safety assurance factors for EHR resilience measure, prior to 2024, providers could answer yes or no on the attestation, and either answer satisfied the measure, but going forward, it will require a yes answer in order for that measure to be fully satisfied. So looking at the scoring, there is no change to the performance threshold. It will stay at 75 for performance year 2024. CMS did clarify that they won't calculate a facility-based score at the subgroup level. We'll dig a little more into subgroups in a moment, but it is a MIPS value pathway consideration, so it is not applicable to traditional MIPS, and there's not a facility-based MIPS value pathway, so that they really just kind of clarified that they won't be doing facility-based scoring at the subgroup level. MIPS subgroups will receive their affiliated groups complex patient bonus points, if any are available. Again, that's clarified in the 2024 rule, but applies to the 23 scoring. And then for performance category reweighting, previously MVP subgroups were allowed to apply for reweighting of some of those categories that we just talked about, but then CMS would have to score the group at the aggregate level, determine whether or not it was available to go down to the subgroup, and really it was just kind of extending the scoring timing. So they just took that away and clarified that the MVP subgroup, if they're applicable, will just get any reweighting that applied at the aggregate level. I think just for housekeeping purposes, really. So you see here the implications of kind of where those scores will land. So we're looking at a -9% payment adjustment for someone that scores between 0 and 18.75. Really, where we see this the most is for individuals that just refuse to report or decline to report. Is probably a better way to look at it. CMS did include some narrative based on an analysis of 2022 information, assuming the same application of extreme and uncontrollable circumstances applications, and assuming the same reweighting that occurred in 2022, they project about 21% of eligible clinicians will receive a negative adjustment. And in their analysis, that the higher percentage than the -9% is most often assessed against solo physicians or clinicians, and again, it's usually based on them just not reporting. For the majority of the providers that report, they fall between a lesser negative adjustment, and really Medicare saying the inverse, about 78% will either receive a neutral or a positive adjustment. Recall that scoring is and the dollars associated with it are budget neutral, so there will only be upside to the extent that there are penalties. Though I do think as we go into 2024, the extreme and unusual circumstances application and those EUCs being granted will decline. Now that some will say that COVID is in our rearview mirror, before they were acknowledging the impact of COVID on the ability to report MIPS successfully, and we're pretty generous, I think, in granting those EUCs, and that conversation and narrative is just not as present as it was before. So I think we'll see some decrease in that this next coming year. So spending just a few minutes on MIPS value pathways, CMS continues to work its plan to funnel eligible clinicians into mechanisms that promote comparability and accountability. And so when you think about, recall that there were the 198 quality measures available, it gave great flexibility, but it also created a little bit of confusion, and it created a difficult situation in order to compare providers against their peers. So one family practitioner may use measures that are totally unrelated to another family practitioner. A gastroenterologist may do the same. They may only use primary care measures where another gastroenterologist might use specialty specific. So that's part of the impetus behind the transition to MVPs, is to really create a funnel where we can bucket provider types, specialty types into using measures that are comparable, so that we can make comparisons to see who really is providing high quality as measured by MIPS to their patients, and really start to create a yardstick, if you will. In the early discussion on MVPs, the diagram was talking about the transition. It's they're building the measures. We'll talk about that. They're building the MVPs. It's voluntary at this point to register for and report via MVPs. In the early guidance, it was indicating that 2027 was the year that traditional MIPS would be sunset. They backed off. I don't see the 2027 as much in print. It's referred to as, it will be sunset in the future. It will end. We don't know the exact year. That 2027 is still hanging out, in the back of my mind as I'm planning and talking with clients. So we'll see how it continues to develop. But bottom line, this is where I kind of feel like MIPS is sticking around, absent some big sweeping regulatory guidance or such, and they're just continuing to refine it as we move forward. Because it is voluntary registration right now, you have to affirmatively go in and register for your group if you are interested in reporting via MVP. You can register between April 1st and December the 2nd of 2024. If your group is going to use CAPS for MIPS surveys, then you must register by June 30th in order to access the CAPS for MIPS. So it's more of the limitation is more related to accessing the survey and registering for the survey than CMS. You can make changes, interestingly, until November 30th of the performance year. So we have a little extra time that you can register for the MVP and not make a change with I think how the dates are falling. When you register, you need to know ahead of time what MVP you intend to report, which population health measure and outcomes-based measure you intend to use or be scored on. You cannot report on an MVP that you didn't register for, so you need to give that some thought ahead of time, but obviously you have a window to make a change if you feel like you need to. Subgroups are breaking down tax IDs, based on NPIs, and so, for example, if you have a multi-specialty group, you can have a subgroup of each of your specialties. You have to register those subgroups. They're voluntary right now, but the plan, at least initially from what CMS is saying, that by 2026, use of subgroups will be required. These are the available MIPS, the available MVPs, and the ones on the left, the 5 on the left, are the ones that were newly finalized in 2024. The ones on the right were previously published and available. They just made some edits within the MVP itself, primarily tidying up, if you will, some of the improvement activities and tying together some of the promoting interoperability requirements, but really more refinements than any kind of major overhaul. Though I did notice, and they did speak, they combined the value in primary care. They took chronic disease management and promoting wellness that were there previously, combined them and made that into one. No real changes here from prior years, but just wanted to kind of remind everybody, each MVP has a foundational layer that is a population health measure. That's recall that you have to sign up for one of those, whichever one you want to be scored on when you register. And then there are also 2 additional measures, and you would choose between the hospital-wide 30-day all-cause unplanned readmission measure or the risk standardization hospital admission rates for multiple chronic conditions. So you would choose when you register which one is applicable for you. And then we'll look at the promoting interoperability in just a moment, but that would apply to all of the MVPs. The topics on the top, the quality, the IA, and the costs, are all specific based on that MVP. So if you were doing an MVP on women's health, the quality measures will all be pre-narrowed and pre-selected. You would choose 4 from the 15 that are available that are associated with women's health, one of which would be an outcome measure or a high priority measure. And you see some other information here. Same for improvement activities, and then cost is obviously handled in the background. So really it is saying that for each of those MVPs that you choose, here's your menu. You a la carte choose within that narrow menu related to that particular specialty. Just highlighting here the specific categories for the promoting interoperability that fall into that base layer. It ties very closely to the regular traditional MIPS PI promoting interoperability category. So no big surprises here, but just wanted to show that, blow it up a little bit so you could see the specifics. So as you're planning on 2024, what do you need to be thinking about? Obviously, evaluate the available options. Evaluate what you're doing now for what you did for 2023. Remember, reporting for 2023 will probably open. It may have already opened for your vendor, but is opening soon and will close on March 31st. So all reporting will have to be done by then. The systems will usually be concurrently building for 2024 and flipping over so you can be aggregating that data. But evaluate all those options and determine what your MIPS pathway looks like for 2024. Don't forget to look for any changes in your quality measures, your improvement activities, that you need to make changes into your operations and how you gather data, where you record that data, and then how you aggregate it for monitoring and reporting so you're certain that you have success. It's not safe just to pick up what you did in 2023 and carry it 2024. Certainly leverage that, but definitely look for those changes so you aren't surprised. We continue to find those organizations that are really integrating and having conversations that include the operations teams, the clinical teams, quality, and the information systems teams for best success. It just touches all of those components in the average clinical practice. If you're looking at an MVP and you want to be an early adopter, you feel like that's the right route for your group, you need to ensure that your vendor can support that MVP data aggregation and reporting. There were some clarifications in the 2024 rules that will impact those third-party providers, so you need to make sure that, you know, as you're going that route, your technology can help you get there as well. Continue to evaluate the alternative payment model options. That really is ultimately where CMS would like us all to go. And you know, there are still organizations that are finding great value in being able to do that, getting additional information, and really easing the reporting burden, though there are other considerations as you go. And I really would be thinking about your MIPS strategy. It's going to change year to year as you have more information, but be thinking for that next 2 to 3 years each year with the information that you have available, and not having it just be an afterthought. So with that, Marty?
Well, Lori, I think I'd add to your list, prepare to engage in advocacy, because I think we're at the point we may be seeing history repeat itself. Yes. As you mentioned, we got MIPS out of MACRA, and MACRA was the solution to the sustainable growth rate fiasco. Because if you remember, again, those of you who have been in healthcare for a while, we reached the point that every single year, the industry was going back to Congress to get a rate hike, because under the SGR we were seeing 20% reductions in reimbursement. Well, the fix in MACRA is now the reason we are all experiencing a 3% reduction in the conversion factor. And we are once again looking at going back to Congress and asking for an adjustment to account for that. And I think it's going to, I'm not one to predict what Congress is going to do in the immediate future, but I think this conversation is going to open up, that we're going to have a broader, longer range solution. I think, yes, part of that will be how do we incorporate an inflation index into the physician fee schedule? And as part of that, I think it's going to be, and how do we make, how do we go? I think, it's the perfect bell curve, right? MIPS started very simplistic. It's now at the top of the heap where it's very, very complex. How do we get it down to simplistic so that it's actually doing what we want? I think this is a real time to be engaging in your experiences under MIPS and MACRA and bringing that to the forefront. I think it's going to be really interesting. Just for an update for you all, Sunday, we finally reached a budget agreement. That's only the amount, right? That's like, this is what we're going to spend. We're now going through the process of how are we going to spend that amount. The first deadline we hit is the January 19th deadline. There are certain budget bills that have to be resolved by that date. HHS and presumably Medicare is on the back end. So we're February 3rd, I believe, is sort of the deadline around that. Of course, Congress can give itself a further extension beyond those deadlines, but that's sort of the time frame we're looking at to see if there is going to be any relief on the conversion factor.
On the conversion factor part.
Yeah. And so, will there be additional funding put into the Medicare fee schedule pie so that we're not slicing out whole chunks at the 3% reduction? So stay tuned. When we talk about future HCRR webinars, we'll highlight that we're going to address whatever Congress does do it to us sometimes at the end of February. So
hold on and wait, right?
Yeah, exactly. It's always interesting. Let's switch gears to our other favorite acronym, MSSP, the Medicare Shared Savings Program. Since the initiation of this program back in 2012, it has effectively lived on the Medicare physician fee schedule rule. Rather than having a separate annual update to the program, CMS decided, I think back in 2015 or so, just to glob on to the Medicare physician fee schedule. And it makes a lot of sense because, as you'll see, there's a lot of synergy between MIPS and the MSSP now, how that program's developed up. And so it makes sense to put these two together. In fact, the fee schedule, we always talk about how long the fee schedule is. Something weighs in at like 1,400 pages in the Federal Register. Well over 700 of those pages are either, the qualifications to the measures in MIPS or the detail, the absolutely mind-numbing detail in the Medicare Shared Savings Program. So they're guilty together, I guess we can say, in the fee schedule rule. So starting with MSSP, a number of changes made this year, some forward-facing that they will impact providers that are part of MSSP ACOs, some that are just more mechanical in how the program works. What CMS is hoping to accomplish is through these changes will increase participation in the program by 10 to 20% this year. Their definition of increasing participation in the program is the number of attributed beneficiaries. They're not looking at how many physicians participate in this program. They're measuring how much of our traditional Medicare population is now attributed to an ACO. 2 years ago, CMS announced its goal that by 2030, 100% of traditional Medicare beneficiaries will be part of an accountable care arrangement. Most significant of that, of course, is MSSP, but there are also the programs within CMMI, such as ACO REACH or Primary Care First, or now Making Care Primary, all of those types of initiatives. So they're really looking for ways to, again, move more and more beneficiaries to these programs. Some of that by providing relief within the MSSP from administrative burden. That's encouraging greater participation, but the primary focus is in how do we get more beneficiaries attributed to an ACO, and thus part of ACO initiatives to reduce quality, to reduce costs and improve quality. Not the inverse, right? We do not want to reduce quality and improve costs. That's not where we're headed, hopefully. So let's start with quality reporting. As Lori referenced, CMS has created these Medicare clinical quality measures. So these are data aggregation measures that what's supposed to happen, the miracle in the EHR system is that it will pull the data on these measures across all payers, across all patients. Appreciating the burden associated with that, for purposes of the MSSP only, CMS will allow the reporting on these measures to be limited to Medicare fee-for-service beneficiaries. And as you see, there are 3 specific measures on which an ACO would report should it choose to do Medicare CQM measures. The issue here, and hopefully CMS will resolve it quickly, is the definition of Medicare fee-for-service beneficiaries, because you're reporting on your attributed beneficiaries. And as you know, if you're part of the MSSP program, it's constantly changing who's attributed to you, who isn't, depending on the particular window you're in. what we had advocated for was that they would be steady based on Q3, so we'd know going into the end of the year who we'd be responsible for. That isn't what we got, unfortunately. So there is still some, it's just not clear exactly how this is to be implemented. Because of that, CMS delayed for a year the elimination of the CMS web interface measure. So this is the familiar, right? We get little lists that say, here are all the people you have to report on this particular measure. We know how to do that. We've been doing it since 2012, in effect. And so CMS says one more year, but this is it. 2024 will be the last year that you'll be able to use the web interface measures. By 2025, you need to be in a position as an ACO to be able to report either on eCQMs, MIPS CQMs, or Medicare CQMs, one of the three. And they also note that they consider Medicare CQMs a transitional opportunity, that they expect that ACOs will develop the internal infrastructure and capabilities to extract data from participants' EHRs so you're able to report on eCQMs or MIPS CQMs.
And Marty, if I could add, I didn't cover it, but that web interface sunsetting in 2020 after this year will also apply to traditional MIPS.
Good. Let's talk about Certified Electronic Health Record Technology, or CHIRT. And again, this is going to align with what Lori talked about in the promoting interoperability category for MIPS. Today in the regulations, an ACO is required on an annual basis to certify that at least 50% of its participants are utilizing CHIRT to communicate clinical information to providers. And it's sort of routine. We sort of all do it because it's not exactly the most well-defined criteria within the MSSP program. But beginning in 2025, so again, 1 year to figure all of this out, and here we are in that year, we are instead now going to require an alignment between the MSSP CHIRT requirement and MIPS promoting interoperability, meaning that any eligible ACO provider, supplier, ACO participant will have to report MIPS promoting interoperability. But remember, you have to be required under MIPS to report promoting interoperability to have to report for purposes of MSSP. So those exceptions that Lori discussed previously in terms of small group, low volume, and the like, if those apply, then that participant does not have to report promoting interoperability. There's a very long and detailed explanation of how this will score for purposes of the MSSP, because it's going to be an aggregation of promoting interoperability scores from all of those individual participants or those provider suppliers that will then become the ACO score for purposes of calculating the percentage of Medicare shared savings received by the MSSP ACO, and also, of course, to meet the requirement for participation in the program. So again, hopefully we'll see some additional guidance come out in either independently or as part of the proposed physician fee schedule for 2025. But appreciate that this is shifting now to an alignment with MIPS. So and again, this applies across the board to all MSSP ACOs. Because previously, if we were in a risk model, so if we were bearing a financial risk as part of our ACO, we enjoyed being a qualified participant and thus didn't have to report on any of these promoting interoperability. Now we are, in fact, all MSSP ACOs are going to find themselves subject to these reporting requirements. So those two requirements, the changes on quality reporting, the changes on promoting interoperability, those are the forward-facing. That's going to change the behavior of your ACO. Let's talk about what CMS is now doing behind the scenes to improve the operations of the MSSP program. And most importantly to that probably is going to be the change in the beneficiary assignment methodology. Because this has always been the issue of how do we account for the fact that there are a whole bunch of people, particularly those where we have health equity concerns. So people in low income communities, people in minority groups, often receive their primary care from a non-physician practitioner. And we don't have a methodology for assigning those individuals to an MSSP ACO because it's always based on the plurality of primary care services furnished by a physician. So this change in the assignment methodology to begin in 2025 is that we will now assign individuals who in the last 12 months have been seen by an MPP, and we will calculate plurality of primary care services in that 12 months. But there's always a but. To be eligible for a beneficiary to be attributed based on MPP providing plurality of primary care services, we will look back another 12 months to ensure that there was a visit with a physician. Okay. So they're looking for that team-based care. Part of the team needs to be the coach, and that would be that visit with a physician. So we're going to look back, check to make sure that the person was seen by a physician in that 12 months. That then makes them eligible. There are, again, lots of detailed changes to the regulation to square up the language to permit this to occur. The good news is this will increase the number of assignable beneficiaries CMS believes by more than 760,000 traditional Medicare beneficiaries. Now, that doesn't mean that those people are all going to attribute to an ACO, but it's going to make them eligible to be attributed to the ACO if the MPP from whom they've been receiving services is part of an ACO. Signal to ACOs, this is an opportunity to recruit now more MPP into your ACO because they will have a more positive effect. Also consider, for those of you that have shared savings distribution models that are based on attribution, which that means the monies have always gone to the physicians, this will change and impact that because now we're going to have individuals that are going to be assigned or attributed to your ACO based on their relationship with an MPP. Benchmarking methodology modifications, which I still believe can only be read and understood by an actuary, because every year I try to read this and I scratch my head and like, whoa, this is complicated. But here are the things that you want to pay attention to because they will have some impact on you. The big change here is HCC risk scores. And we well know, folks in the MSSP, that part of our success in earning shared savings is being sure we've captured all the risk in our population through accurate coding, proper documentation, and reflecting in our claims data the diagnoses of our attributed beneficiaries. And that has been tied historically to the current version of the CMS HCC risk methodology, which currently, well, kind of currently, if we could go back to December 31st, it would be currently version 24. But beginning with in 2024, CMS is now transitioning to version 28. And if you have delved into this to any degree, 28 is a pretty significant change from 24 because we've changed the weighting of certain HCCs. So that HCC, depending on which ACC you're in, it's getting a greater weight or a lesser weight. So we have adjustments to those. We have some diagnoses that have completely gone off HCCs. So they're no longer a listed HCC because CMS has determined that a person with that diagnosis, in fact, does not have an increased spend as compared to others. So this has been the topic, well, not the topic, but one of the topics in the Medicare Advantage space, because the MA plans are being hit with this. So CMS is now, over the next 3 years, phasing in version 28, and thus changing risk scores for Medicare Advantage plans, meaning that directly impacts how much the MA plan is paid by CMS. And so there's a great deal of concern in that space. So what CMS has done in the 2024 final rule is their best effort to align with what's going on in MA to the MSSP program on the assumption that we want aligned initiatives around capturing risk within our population. So beginning with agreement periods of this year and moving forward, when we calculate the benchmark that ACO will be measured against, we're going to use the HCC methodology in effect as of the current performance year. And we will acknowledge the phasing in of version 28 that's aligned with Medicare Advantage plans. So that aligns from, is it this year? It's 1/3 28, 2/3 24. It flips then next year to 2/3 28, 1/3 24, and then by 2027 fully implemented over to 28. For MSSP benchmarking purposes, it'll follow the same path. And so but rather than applying the HCC methodology that was in effect during that benchmark year, which is what they currently do, they instead now will retroactively apply the appropriate 24-28 measure. What this means is if you are an MSSP ACO that has engaged in activities to capture risk in your population, we need to reevaluate those programs to make sure you're capturing the right risk within that population as it impacts your HCC score. Because as you appreciate, as you capture more risk within your population, that impacts your benchmark. And when your benchmark goes up, as it would when you have a higher HCC score, it's easier to earn shared savings. CMS also is making some changes to the regional component and the three-way blended benchmark update by capping the risk score growth in an ACO's regional service area. And this has been the regional penalty issue that has been in play, that if as you as an ACO improve, there's a negative impact on the regional adjustment as a result of your improvement. Thus, we're encouraging more participation by ACOs in regions with high risk score growth by symmetrically linking the two. So that is intended to address that issue, as is also the elimination of the overall negative regional adjustments, again, going forward now in 2024. Finally, let's talk about the modifications that CMS has made to the Advanced Investment Payment Program, which is launching this year. Certain qualifying ACOs are eligible for advanced shared saving payments to support necessary infrastructure development. This is limited to new ACOs within the low revenue category. And we have new participants in the MSSP program who will be participating in these advanced payments. It's not free money. Well, it kind of is free money, but it will always be subtracted from any shared savings payments that you receive. It's free money to the extent you never earn shared savings, and thus you never have to pay it back. But CMS has finalized several refinements to the AIP program, all to support implementation. When can you move, if you're in an AIP ACO, when can you move to downside risk, how we are going to deal with participation of your renewal of your agreement without triggering full recoupment, and then allowing you to immediate termination in future quarters of payments if an ACO voluntarily terminates. As the regs were originally published, you could terminate out of the program and still receive quarterly payments to your ACO, which didn't make sense. So they fixed that as well. So this will be, again, this is CMS effectively crossing the T's and dotting the I's into the AIP program. It'll be interesting to see. CMS has not yet released the data for 2024 participation. I had crossed my fingers and hoped they had, but last year it was about the third week in January when they finally released those participation numbers. But we'll see if, in fact, adding the AIP program will positively impact participation in the MSSP program. In our last few minutes here, and we have about 10 minutes here to go, let's talk about these services addressing health-related social needs. These are new reimbursement available under the fee schedule for providers who are actively addressing the health-related social needs of their beneficiaries. And there are, this is tied really to CMS's overall health equity priorities. This is a this comes from the 2022 Health Equity Plan developed by CMS. How are they going to pursue initiatives that promote health equity within the Medicare program and more broadly through the healthcare system? And they've identified these priorities. One of those priorities is how do we pull regulatory and payment levers to incentivize health equity activities among the provider population. And you just see here what we've identified as those levers over the last couple of years. The one I want you to pay attention to in particular is number 9, is state Medicaid program reimbursement for community health worker services. And about more than half of the states now in their state Medicaid program have developed some vehicle for reimbursing services by community health workers. And a community health worker is an individual who is not trained medically. They do not qualify as clinical staff, but they are social service navigators and assist patients in addressing health-related social needs. So they are, I think, navigator, though I think navigator tends to have a clinical component to it. But these are the community health workers. This program has been really popular among the health-related home and community-based services. Wow, fell out of my head there for a second. But Medicaid home and community-based service programs, they have woven in this reimbursement for community health workers to ensure that those folks are able to provide services to appropriate Medicaid beneficiaries. Well, what's happened now in the Medicare program is CMS finding the vehicle to reimburse community health workers. Remember, we have a whole range of care management programs, chronic care management, remote patient monitoring, all of that, but they always have a clinical staff element to them. This is now the reimbursement for the community health worker instead. So let's talk very briefly about the reimbursement for these new services. The first is the social determinant of health risk assessment. New reimbursement, relatively low reimbursed, as you see at the bottom of the page. But this is time spent either by the billing practitioner or clinical staff under general supervision, administering one of these standardized evidence-based risk assessment tools. This is not screening. That's the most important. If you remember nothing else, this is not screening. This is a physician or a non-physician practitioner has identified that there must be something going on with this patient, some health-related social need. I want to get my hands around it so that I can better diagnose and treat this patient going forward. So once the physicians identify that need for this risk assessment, that is when this would kick in. It can be performed every 6 months. It doesn't have to, the big change from the proposed rule to the final rule is it does not have to be performed on the same day as an E&M visit. It can be performed by clinical staff as long as you meet the incident 2 requirements, and it can be done via telehealth so that you don't have to have the patient right in front of you at the time as you see going forward. You see there the recommended tools to use for these assessments, and you see the payment rates. I think there's an opportunity here, particularly for hospital-based practices, to align this with the hospital inpatient quality measure that requires screening for inpatients. That screening is going to identify potential needs. This then gives you the opportunity for performing the risk assessment and capturing that additional reimbursement. Let's talk about community health integration, or CHI, G0019 and 22. This, again, a service that would be performed by typically a community health worker. The elements here, they're pretty well defined. I think CMS did a really nice job between the proposed rule and the final rule, detailing out the requirements to bill for this particular service, making very clear that there needs to be an initiating visit where a billing practitioner identifies the presence of SDOH needs, and that they think it's appropriate to have assistance offered to that individual to manage those services. Those services then are trained by either certified or trained auxiliary personnel under general supervision of the billing practitioner. That certified element goes to those states that have in fact created a certification program for community health workers. The trained auxiliary personnel goes to those states that do not have that certification presently. again, regulation spells out what that training should include for that individual to then be qualified to provide CHI services. This is a 60-minute code, capturing 60 minutes of time either spent with the patient or on behalf of the patient. And then there is additional 30-minute increments. Interesting, unlike our care management codes, there are no limits on the number of G0022s that you can bill. So if it takes 3 hours to work with this patient, so be it. We're going to pay you for 3 hours of working with that patient. And you see there the service elements for this new code. Interesting question I discussed with a client today. That is, I'm in Kansas City, beautiful snowy day, but we are one of the primary care first regions. And PCF practitioners cannot bill for chronic care management services because the population-based payment that they receive is assumed to incorporate that. And when CMS published the December 23 guide for program year 24 within PCF, it again goes back to you can't bill for these CCM codes. But nothing is said about community health integration or principal illness navigation. So this potentially can become a vehicle for additional reimbursement for PCF practices, and as they are providing navigation services, even if they're using clinical staff to perform those navigation purposes, if they are in fact meeting the requirements of this. So I think it's an interesting opportunity, not addressed in the final rule, not addressed in the PCF documents. So it could be an opportunity for additional revenue for the work you're doing already as a PCF practice. More details around CHI with regards to the documentation of activities. Very clear that only one practitioner can bill for this service within a given month. There is a consent requirement, either oral or written. Clear that we can provide the service along with other care management services being purchased to the individual so long as we're not double counting. And you can arrange to have a third party, such as a community-based organization, providing these services as long as you maintain a sufficient degree of clinical integration. Lori, if I just knew the definition of sufficient level of clinical integration, but we do our best to figure that out to ensure that there's at least access to a record that's shared between the parties on that. And again, you see the reimbursement for these services. The other added code is Principal Illness Navigation, or PIN. Very, very similar to CHI, except who qualifies. So rather than being based on the need for based on identified social determinant, instead this is an individual that's been diagnosed with a high-risk disease, cancer. The example from the rule are cancer, COPD, dementia, severe mental illness, or SUD, and a determination by the billing practitioner that this is expected to last for a period of time. It creates a significant risk for the beneficiary, and it requires some engagement with a person that would be a community health worker. And from there on, it becomes very, very similar to CHI. The one exception, and boy, I hope they fix this, is in their discussion of the consent requirement for PIN. They say, oh, you have to grab consent every year. That's not in every other care management code, and for CHI, it's an in perpetuity, there's the word, consent. But for PIN, it has to be renewed annually. I think part of the expectation is you wouldn't necessarily be receiving these services over a long period of time, but again, why make the rule differently for this one? And also the other exception is PIN can be billed by two practitioners, but only in limited circumstances. There is also PIN peer support, which is simply, there are certain folks that are peer support specialists that wouldn't meet the definition of community health worker. Their scope of practice would not allow it. And so they've made an exception and created this very specific code. Last but not least, very briefly, I want to talk about changes that were made to rural health clinic and federally qualified health center care management services. This is the vehicle that's used by those organizations to bill for care management services. You see what was included for 2023 and 2024, significant expansion to include CHI services, principal illness navigation, as well as the remote monitoring codes, and thus allows for community health worker reimbursement within RHCs and FQHCs. The big difference here was the CMS determining that you can bill multiple units of G0511 if you're providing multiple services to the beneficiary. That's directly contrary to the guidance we got in December of 19 on this issue. But this really, again, opens up an opportunity for RHCs and FQHCs to be broadening out those services they're providing as a matter of health equity. So there we have it, a quick run through those new codes. What are we doing? What's coming next? January 24th, 2 weeks from today, our next HCRR coming to a state house near you. After 2 years of focusing only on federal issues, we decided it was time to see what's going on in the state house in your local areas, because what we're seeing is once one state does it, other states follow. So kind of try and give you that broad perspective. Then on February 7th, I've harangued Lori as well as 2 of my other colleagues. We're going to bravely do a webinar on G2211.
They're going for it.
Oh boy, we're here that CMS has some guidance that's going to be coming out in short order on billing 2211. Boy, we can't wait for it. We are sponges waiting to soak that up, but we will delve into that on February 7th, hopefully from a very broad perspective and trying to be as practical as we can for implementation. So with that, Caitlin, back over to you.
Thanks to our presenters, Lori and Marty. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides of the recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, which is pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete that short survey and post any questions that you may have. On behalf of PYA, thank you so much for joining us, and we hope you have a great rest of your day.